Today's topic: retention and relapse. Contents: introduction, history, basic theorems of retention, necessity of retention, and conclusion. Introduction. There is a saying, it's not over till it's over. In orthodontics, although the patient may feel that treatment is complete when the appliances are removed, an important stage lies ahead. Orthodontic control of tooth position and occlusal relationship must be withdrawn gradually, not abruptly, if excellent long-term results are to be obtained. Dept defines retention as the holding of teeth in ideal aesthetic and functional positions. Teeth that have been moved in or through bone by mechanical appliances have a tendency to return to their former positions. Orthodontists have long been aware of this fact. It is a purpose of retention to counteract this tendency. The requirements for retention are decided at the time of diagnosis and treatment planning. The correct diagnosis, logical treatment plan, and the timing of the treatment plan must be directed towards ideal aesthetics, ideal function, and the permanent maintenance of these ideas. Relapse can be defined as a return toward the pre-existing condition, and relapse of teeth after orthodontic treatment has been a topic of persistent interest throughout most of this century. Angle stated that the problem involved in retention is so great as to test the utmost skill of the most competent orthodontist, often being greater than the difficulties being encountered in the treatment of the case up to this point. Tweed stated that determining the anterior limits of the denture was the key to the stability. Moving to the definitions of retention and relapse, Robert Moyes states that relapse is a term applied to the loss of any correction achieved by orthodontic treatment. In 1969, Horowitz and Hickson defined relapse in general as changes in tooth position after orthodontic treatment. Riedel believed that the word relapse was too harsh a description of the changes that follow orthodontic treatment, and he preferred the term post-treatment adjustment for these changes. Moyes defined retention as the holding of teeth following orthodontic treatment in the treated position for the period of time necessary for the maintenance of the result. In 1985, Dept and Riedel explained retention as the holding of teeth in ideal aesthetic and functional positions. Retention is accomplished by a variety of mechanical appliances. Moving to the history of retention, for many years clinicians did not agree about the need for retention. Hellman said, "We are in almost complete ignorance of the specific factors causing relapses. Different philosophies or schools of thought have developed." The occlusal school. Kingsley stated the occlusion of the teeth is the most potent factor in determining the stability in a new position. Many early writers considered that proper occlusion was of primary importance in retention. The apical base school. Alex Langston have apical base school in the middle 1920s. This suggested that the apical base was one of the most important factors in the correction of malocclusion and maintenance of correct occlusion. Macaulay suggested that intercanine width and intermolar width should be maintained as originally presented to minimize retention problems. The mandibular incisor school. Grieve and Tooth suggested that the mandibular incisors must be kept upright and over basal bone. The muscular school. Rogers explained the necessity of establishing proper functional muscle balance. Orthodontists have come to realize that retention is not separate from orthodontic treatment but is a part of treatment itself and must be included in treatment planning. Stability has become a primary objective in orthodontic treatment, for without it either ideal function or ideal aesthetics or both may be lost. Retention depends on what is accomplished during treatment. care must be exercised to establish a proper occlusion within the bounds of normal muscle balance and with careful regard to the apical base or base available and the relationship of these bases to one another. Next, basic theorems of retention. Theorem number 1: teeth that have been moved tend to return to their former positions. The influence of musculature, apical base, transeptal fibers, and bone morphology has been suggested as the reason. Hence, many clinicians agree that the teeth should be held in their corrected positions for some time after changes are made in their positions. Theorem number 2: elimination of the cause of malocclusion will prevent recurrence. The elimination of the causating factors such as habits, for example, thumb or finger sucking, or lip biting, or mouth breathing, are important in regard to retention. The most insidious habit that operates against satisfactory retention is tongue posture and function, which results in anterior and sometimes lateral open bites. Theorem number 3: malocclusion should be overcorrected as a safety factor. Many orthodontists overcorrect class 2 malocclusion to an edge-to-edge incisor relationship. Quesenberry's study suggested that the most retruded mandibular position can be determined and reduplicated after release of these mechanics. Class 2 forces tend to have their greatest effect on the tooth position rather than jaw position. Overcorrection of debite is accepted and over rotation of the rotated teeth is being done in order to prevent relapse tendency. Theorem number 4: proper occlusion is a potent factor in holding teeth in their corrected positions. According to Calvin S. Case, the occlusal interlocking of cusp and other harmonious relations afforded by a normal occlusion are of very greatest importance to retention. Theorem number 5: bone and adjacent tissues must be allowed to reorganize around newly positioned teeth. Histologic evidence shows that the bone and tissue around the teeth have been moved there altered and considerable time lapses from complete reorganization occurs. Some authors have suggested the use of fixed retainers. Others believe that retainers should be used only inhibitory in nature and have no positive fixation to allow for natural functioning of teeth. Oppenheim suggested that appliances should be only inhibitory and the repair of tissues around the teeth occurs much more rapidly if no fixed retaining appliances is used. Theorem number 6: if the lower incisors are placed upright over basal bone, they may more likely to remain in good alignment. Mandibular incisors should be perpendicular to mandibular plane. When the teeth are aligned with a labial inclination, attempts to push them lingually results in expansion in canine area or collapse of the teeth. The mandibular arch forms plays a more important role in stable mandibular tooth alignment than does the relative antero-posterior relationship of mandibular denture to the base. Changes in muscle balance because of the changing the position of teeth in normal direction allows for more normal development of the dentition in relation to retention. Normal muscle balance should allow for normal arch alignment. Theorem number 7: corrections carried out during periods of growth are less likely to relapse. Orthodontic treatment should be instituted at the earliest possible age. Early diagnosis and treatment planning afford several advantages in long-term stability. Theorem number 8: the further the teeth have been moved, the less likelihood of relapse. When it has been necessary to move teeth a great distance, the patient will need less retentive attention. Theorem number 9: arch form, particularly in the mandibular arch, cannot be permanently altered by appliance therapy. The treatment should be directed towards maintaining the arch form presented by the malocclusion. The attempts to alter the mandibular arch form in the human dentition generally meets with failure. Moving to the necessity of retention. As the orthodontic treatment results are potentially unstable, the retention is necessary for three major reasons. 1. The gingival and periodontal tissues are affected by the orthodontic tooth movement and require time for reorganization when the appliances are removed. Second, the teeth may be in an inherently unstable position after treatment, so that the soft tissue pressures constantly produce a relapse tendency. Third, changes produced by growth alters the orthodontic treatment result. These are the causes of relapse after orthodontic treatment. Elastic recoil of the gingival fibers and cheek or lip or tongue pressure causes intra-arch irregularity. Differential jaw growth and cheek, lip, tongue pressure cause changes in the occlusal relationship. Retention is not a separate problem or phase of orthodontics, but is and will continue to be a problem to be considered in diagnosis and treatment planning. Oppenheim phrased it: retention is one of the most difficult problems in orthodontia. In fact, it is a problem. Thank you.